Chapter 29 discusses bleeding and shock. We're going to talk about just a quick review of the circulatory system and then review on what shock is defined as, and then some bleeding. So the main components of the system, of course, is the heart, the vessels, and the blood itself. The heart's job is to pump that blood, supplies oxygen, nutrients to the body cells. We know that it needs to pump at an adequate rate and rhythm in order to perfuse the body adequately. Your arteries carry that oxygenated blood away from the heart, except for the pulmonary artery, which carries deoxygenated blood away from the lungs. They are thick, they have muscular walls that enable dilation and constriction. So you know that your arteries are powerhouse. They have a lot of force. They've got a lot of volume. So if we see a bleed with the arteries, there's going to be an issue, right? The capillaries are microscopic. They're smaller, but they're a vital exchange site. They are the site where those oxygen nutrients get exchanged to those capillary walls in exchange for the carbon dioxide, right? So veins carry that oxygen depleted blood rich in carbon dioxide back to the heart, except for the pulmonary vein that brings in oxygen rich blood into the heart. They do contain one-way valves to prevent a backflow of blood. So that's what you're seeing when you see those splits on your veins, on your hands. You can see them pretty well. Those are valves. So shock in itself, we know that is defined as inadequate tissue perfusion. If hypoperfusion, low perfusion persists, we know the cells and the organs will ultimately die. So pretty tough trauma patient there. It's got a lot going on. Definitely got multi-system problems. So pathophysiology of shock, 4 causes of shock. It could be a volume problem where you've got a volume compromise, a pumping problem, blood vessel tone problems, or something is obstructed. So you've seen this diagram before in earlier chapters. So kind of just reviewing the different types of shock. I like how this diagram kind of encircles it like that. Hypovolemic shock being that hemorrhage of blood loss. Don't forget about just fluid loss as a whole, and burns. Obstructive being tamponade, cardiac tamponade, a pneumothorax, an embolus or a clot, or congenital heart disease. So there's your obstruction, right? It's obstructing something, obstructing perfusion. Cardiogenic has to do with the heart, you know that. Neurogenic has to do with the brain, the CNS, central nervous system. Distributive, just think of that as it distributes through the body. So sepsis, right? So infection getting through the body, anaphylaxis, drug ingestions, kind of distributing through the body. So hypovolemic, your blood is lost, plasma is leaving. We don't have enough volume in the vessels. So therefore, of course, because cardiac output is compromised, the pressure starts to fall. Absolute relative hypovolemia, hypovolemic shock is the other term for that, okay? So hemorrhagic shock is the loss of blood. Remember, hypovolemia has to do with volume. It's not just blood. It can be fluid imbalance as well, dehydration. Pumping problems caused by that failure to pump blood adequately, usually is a mechanical issue. Blood's not moved adequately because of a drop in that pressure. We categorize that as cardiogenic shock. So all your blood vessels dilate at the same time, and they cannot fill the entire circulatory system, okay? So referred to as distributive shock. So your tone, your vessels try to constrict and dilate to maintain balance, maintain cardiac output. If something disturbs that, they can't perfuse adequately. They can't dilate and constrict adequately. So if everything dilates all at the same time, we're going to have a drop in pressure big time. So distributive shock here, anaphylaxis, neurogenic septic shock. Like it distributes to the system. obstruction of blood flow. So your blood flow itself is blocked. So pulmonary embolism, pulmonary being in the lung cavity, embolism being that clot or that could be an air embolism as well. Cardiac tamponade, where there's too much fluid around the heart. Tension pneumothorax, where we've got so much air coming in from the outside into the lung cavity that it actually causes lungs to collapse. So when we're looking at shock, we talk about fight or flight or the sympathetic response. So sympathetic versus parasympathetic, and knowing the difference between those two. Your parasympathetic system, just think of that as a pair of cool cats. I know it's corny, but parasympathetic, cool cats rest and digest. Everything's great. Homeostasis is in order. The sympathetic one being the opposite. Your baroreceptors stimulate epi and norepi, and you start to get some fight or flight response mechanisms. Your vessels constrict. Okay? Skin becomes cool, pale, diaphoretic. The kidneys produce less urine. You could be getting some GI from the systems basically slowing down in that GI cavity, so nausea and vomiting. And then your heart rate and is going to go up, as well as its contractility. So of course your body tries to compensate when it's in shock. All right. It recognizes there's some sort of decrease in perfusion. It attempts to compensate for it. All right. Wants to restore blood flow. It wants that cardiac output to be the same. It's trying to regulate that volume. It's trying to, constrict, dilate, what it needs to do on these vessels to get things to work right. Okay. So when the body is in this state, we call it compensatory shock or compensated shock. Right. Kids are a little different. In an adult, when we have shock, we look for trending, right? We look for, are the heart rates increasing? Is the blood pressure decreasing? Infants and kids, they pretty much try to compensate until they no longer can, and it's like them dropping off a cliff. Okay, so we never wait for drop in pressures to identify shock in PEDS patient. We look for the heart rate and we assume they're in shock. Okay, so treat accordingly. We don't want to wait until it's really late in the game here to treat these PEDS. So of course, when you're in compensated shock, your body's going to need more energy, more fuel. It is trying to balance itself out. When that fuel starts running out, your body's going to start stop having enough energy to compensate. Here's where you're going to start seeing, if you haven't seen an altered mental status, you're going to see a bigger change in that. You're going to actually see a drop in the blood pressure. Remember, that's a late sign of shock. And then the heart rate and respiratory rate are going to start to slow. You are losing your patient. This is late. Okay. Prolonged vasoconstriction, organs aren't being fed, brain's not being fed adequately. And ultimately, if they get to a state of irreversible shock, no interventions are going to change the outcome. They are going to die. So identifying when we do assessments, identifying what's going on, what's the problem, what is causing my patient to be in shock. Recognizing those compensatory measures. Okay, what do you have on? What is the MOI? What's the nature of illness? What do we see here? Get your primary done, right? Make sure your patient is an airway, breathing, circulatory taken care of. If they need some assistance there, definitely get that taken care of. We do not want patients to become hypoxic, period. You know that by now. Supplemental oxygen, depending on what you have for adequate versus inadequate breathing. Circulatory, take a look at the skin color. Is it pale, cool, diaphoretic? What's the cap refill? Is it greater than 2? Are distal pulses present? So in shock patients, as they get later into shock, we're going to start losing distal pulses. The body knows to shunt the blood to the core. It knows it needs to do that to keep organs and brain perfusing and heart getting the correct cardiac output. So Treat those problems in the primary immediately, just like you always would. Treating for shock, EMT basic, is oxygenation. Okay, making sure you keep that patient warm to try to compensate for that vasoconstriction. And keep watching that trending and vital signs. Are you seeing drops in pressures? Have we looked at everything that could possibly be going on with this patient? Get your history taken, what's going on today, what happened today, or the mechanism of injury. What is your patient's chief complaint? All right. So this diagram's in your book. It just kind of shows you. So when this starts, your heart rate starts to increase, right? We still need the volume. So as vasoconstriction happens, we need to, your heart's going to want that same output regardless. So it's going to start, heart rate's going to start to go up. As those vessels constrict more, you're going to see pale, cool, clammy skin. Since your heart rate is going up, your respiratory rate and that oxygenation process is also going to speed up to keep up with your heart. As it continues on, if it's left untreated, blood starts shunting away from your GI. Okay, it's going to need to go to a more, I shouldn't say serious area, but the GI system in comparison to the heart and lungs, comparison to the brain. You get what I'm kind of saying. So the GI system is going to start causing some nausea, and then a decrease in blood pressure is definitely a late sign of shock. So if we don't intervene immediately, it's going to become irreversible shock, and it can lead to our patient's death. So treatment, well, it depends on what we got going on here, right? If they're bleeding, stop the bleed, stop that hypovolemia from happening. If they have low oxygenation, get that taken care of. The best way to stop shock is to stop what's causing it. It may mean surgery, and we aren't surgeons, but use your primary assessment, your life threats. You know what those are now. Okay, get those oxygenation going, get that patient, keep that patient warm, that patient talking, make sure they've got a good sugar level. All right, make sure that we've got some things that we can treat out in the field so we can prevent that. So you might hear of the deadly triad of trauma, all right, and severe blood loss. So this is a great little chart, all right. So severe blood loss, as blood is being lost, there's going to be less oxygenation. There's going to be an increase in lactic acid, right? The body becomes acidic, more toxins are being built. The heart can't perform as well. We have hypothermia on board because we've got vessels constricting, and therefore we've got decreased coagulation. So that deadly triad of trauma, we need to stop that. So by stopping the bleed, by oxygenating our patient, and by keeping our patient warm, we are definitely cutting down the chances of this triad becoming successful in taking our patients. So definitely on these shock patients considering ALS, we can get fluids started, other medications possibly, getting additional help if you've got a patient that's, in a severe phase of shock, or you feel you need ALS intercept to get some of those interventions started. Rapid transport, we're not going to take a ton of time on scene. Manage your ABCs as you always do. Prevent heat loss. Make sure your patient's laying down. Request ALS. Okay, so bleeding, hemorrhage, term for major bleeding, is one of the major causes of shock and trauma. We can be external or internal. So external, of course, being easier to see. Obviously, internal, we're going to have to do some physical assessments and be looking at some vital sign trends, etc., to figure out if we've got an internal bleed. So externally, there's your artery, the arterial arteries, squirting blood, it's pulsating. You're not gonna, you'll definitely know what this is when you see it on scene. That pulsating happens when the ventricle, left ventricle contracts. So as they're spurting that blood, definitely fast blood flow loss. Okay, so arterial bleeds are a huge life threat. Venular bleeds, they can be major bleeds as well. It's more of a steady, slow flow. You're not going to see that spurting blood with the heart pulse. They're darker red in color. And then your capillary bleeds, slow, even flow. Bleeding is controlled pretty easily with pressure. So external bleeding, the force something penetrates the skin, destroys the vessels, and we see that bleed. So how much are we having on the bleed? You're going to need to take a look. How large is the wound? Try to estimate how big it is, how deep it is. Is there a vessel that we need to be concerned about that's close to that wound site? Right. We also need to consider our patient's ability to clot. Okay. All trauma patients should be asking them if they're on a blood thinner. If they're on a blood thinner medication, and definitely going to increase the chance of them bleeding out faster. So massive hemorrhage, there's your arterial bleed, bright red in color, squirts, oxygen rich. Your venous bleed is darker in color than arterial, and it is not bleeding with that kind of force, but we do have some large veins that that if they are severed, they can create life threat bleeds. All right, so just don't discount venular bleeding just because of that. Look at how much blood volume is lost and make a determination from there and get that bleed stopped. Right. Junctional hemorrhage. So the appendages of the body connect to the trunk there. You can see the legs on this individual, military person. Those arteries and veins that flow through there are not very well protected. So blunt force or a direct injury is likely to cause those to massively bleed. Those are going to be tough sites to stop bleeding. So other bleeding, capillary, usually not life threat. All bleeding needs to be stopped regardless if it's a arterial or venular or capillary bleed. It's just that some of those take priority over others, depending on the amount of blood that's lost. And of course, with an arterial bleed, with that spurting going on with the ventricle, we need to stop those bleeds. Those are life threats. So we already talked about prescription meds design that we need to ask those about blood thinners. Hypothermia. That's the vasoconstriction, the hypothermia, our patient becoming pale, cool, diaphoretic, is definitely going to affect their body's ability to clot. Okay, so any hemorrhages, let's start with direct pressure and try to get that bleeding under control. So when we talk about blood loss, like what is severe? So think of those liter bottles of pop. Okay, so more than 1 liter, because that's an adult there, 5 liters about. More than 1 liter is considered severe. Okay? More than half a liter in a child, and more than 100 to 200 cc's in an infant. So just keep that in mind. An infant may not look like a major bleed, but if you look at 250 mils or 250 cc, same thing. That's not a lot. Okay, that's not a lot. Proper PPE, absolutely right. We don't want to get people's blood on us. So anything that can possibly spill into an orifice, cover. All right. So gloves, mask for sure, your goggles, possibly a gown, wash your hands, switch out your gloves in between patients. So identifying and stopping these massive hemorrhages, these large bleeds, not capillaries, right? But these large bleeds, you need to stop them. You're going to switch to CAB here, okay? Stop the bleeding, get your airway, then breathing, okay? So like I said, control that non-massive bleeding only after getting your primary threats taken care of, okay? Do not look at your mechanism of injury. Look at how people are, how your patients are bleeding. Look at what's going on around you. Don't wait for vitals to show up as crappy. Treat for shock. Okay. It's not going to hurt them. Cover it up on a blanket. Not going to hurt them. Giving them oxygen. It's not going to hurt them. And definitely stopping the bleed. So we talk about methods of controlling external bleeds. Direct pressure, of course, first and foremost, get that bleeding clotting process initiated. We do have hemostatic agents or quick clot that we can use on the core to try to initiate that clotting process. Packing wounds and just piling and packing and putting pressure on them. We have tourniquet use on the extremities if pressure and wound packing is not working. And then there are some specialized devices for junctional bleeding. So stop the bleed, we know that. So even if you've got to come up to a patient and use your gloved hand to stop it while you're getting other materials ready, do that. Don't lift layers of dressing once you start placing it, okay? So get a good look at that wound. Once you start dressing that wound, we don't peel it back to take a look again. Now you just reversed our clotting initiation, so do not do that. So keep layering dressing on those wounds. Junctional areas is going to be very tough. Remember with the junctional areas, those joints coming into the cavities. You're going to have to probably use pressure and packing. Okay, so direct pressure and packing packing the wound and using hemostatic gauze or quick clot so it can assist in that clotting process. All right. So these hemostatic agents usually comes in the form, it's called quick clot. It's impregnated gauze. So the quick clot powder is built into the gauze or into the dressing. Very, very helpful for wound packing. There it is. So you're going to put pressure on this patients where the bleed is, and then you're going to, with the other hand, you're going to pack the wound and continue to pack the wound. Okay. If you've got an extremity that we cannot control with direct pressure or with additional pressure dressings, we're going to have to tourniquet. So remember, when you put a tourniquet on, it's going to stop all the blood flow to and from that extremity. Okay. You're going to always apply that tourniquet between the wound and the heart. So think of tourniquet starts with a T, tourniquet toward the core. That tourniquet needs to be away from the wound toward the core. So about 2 inches above the wound, you're going to tourniquet that, and you're going to keep turning that tourniquet until the bleeding has stopped, and the pulses, you could have, or the pulses will probably be absent in that extremity. Okay. There's a place to mark the time of application. Make sure you do that. Remember, once this is kind of a last ditch effort to stop bleeding, they could be susceptible to losing that arm or leg, but they're still alive. Okay. So if you don't stop that bleeding, they're not going to be. So tourniquet use is going, probably could cause some tissue damage, but if it's not applied, they could lose their life. So junctional tourniquets, there's a specialized one. It's kind of like a big tourniquet. You might see these in specialized areas. Puts pressure in the axle and groin area, tries to help control that bleed. If you don't have that for the junctional area, definitely use your hemostatic agent or your quick clot to try to control that bleed. If you use quick clot, okay, let's back to this. Make sure that you tell the hospital upon your handoff report that you have quick clot on board. As much as we have been really cool in saving a patient's life, the surgeon is going to have to go in there and unclot it. So he's not going to really like that, but they get it. We didn't have a choice, but just make sure that you're telling the hospital that quick clot has been administered to a wound. You can try to elevate an extremity above the level of the heart to try to just slow down that bleed. As long as we don't have a musculoskeletal injury, an impalement, or any C-spine problems or any spinal injury problems, you can do that. Splinting helps stabilize. It helps with pain, and it helps from, if there's broken bones rubbing together and causing more bleeding. Splinting will definitely help. Air splints will help. Cold is great. Cold is good for a lot of things. It's good for swelling. It's good for pain control. It starts to constrict the vessels, so we're not losing as much blood. So you're going to use it, though, in conjunction with something else, right? So whether you're splinting or whether you're dressing and bandaging, cold is definitely an asset. Make sure when you do cold packs that you have something between the pack and the skin. Okay, we don't want that pack directly put on the skin. We don't want to damage any of the epidermal layer, the dermal layer, epidermal. There you go. Head injuries. So special situations involving bleeding. So the head injury from increased ICP. So With this one, I just got done telling you that we want to put pressure bandages on bleeds. However, with the head, since there is not a lot of give, all right, in the skull area, you are going to want to try to control the bleed somewhat, but we do not want to pressure tight bandage it, okay? Because the brain doesn't have a lot of area to swell, if it's been impacted, we do want that drainage to flow freely, use gauze pads to collect it, but we want to keep that intracranial pressure down, all right? So allow those heads, make sure, you're controlling the bleed, yes, but not packing it so tight that it can't breathe or it can't flow, right? We want to keep ICP down. If we don't keep that intracranial pressure down, the brain could possibly herniate into the brain stem and they'll go into cardiac arrest. So epistaxis or a nosebleed. No, do not have your patient lean back like they do in the movies and all that. No, bad. Nosebleed, have them sit and lean forward. Put pressure right on that fleshy portion of the nostril. Okay. Try to calm the patient down. Especially if they've got a major nosebleed. I've had patients that have nosebleeds and they're on blood thinners, and I feel so awful for them because it's like it is pretty scary when you see like all these tissues just full of blood. And then we have to end up taking them in. They do what's called a cauterization, where they basically burn the vessel that's causing the bleed, the poor people. But anyway, so don't have them lean back. If they pass out or they become unconscious, get them in that left lateral recovery. Be prepared to suction, okay? Because the nosebleed is coming from that sinus cavity, and it definitely can cause some choking problems if they're unresponsive. So be ready for suction. So patient care, take a look at, direct pressures are first and foremost go to. Hemostatic agents or quick clot if we need to assist the body in clotting. Do we need to pack the wound? Do we have a junctional tourniquet? Do we have to use quick clot? If direct pressure fails, if it's not working quick enough, you'll have to apply a tourniquet, and we'll go through that during skills tourniquets. Rapid transport, of course, you are having a patient that's losing volume. So also consider the need for ALS so we can replenish some of that volume. Okay, internal bleeding, internal organs, vessels. We know there's lots of vessels. Blood loss commonly can't be seen. That's part of the problem. So we're going to have to do a good physical assessment. We're going to be palpating areas of the body to see if we can note decap BTLS anywhere. So this gentleman here, blunt trauma, looks pretty nasty. I'm not really even sure what would cause that if something fell on him. Remember, bruising like that. Normally you hit your leg and it takes a couple days for a bruise to be that dark. This gentleman here has it upon accident. So we know that is signifying we've got a major internal bleed there. So penetrations, remember what's going on outside that you see. There's a nice gunshot wound for you. We know gunshot wounds go all over the place. So it really can be causing some internal bleeding for our patients. So signs of internal bleeding, if we see bruising like that, swelling, tenderness over the vital organs, all right. Rigidity, if you're palpating the abdomen, deformed, swollen extremities, right extremity should equal left extremity if something looks weird. Bleeding from the mouth, the rectum, the vagina, any of the orifices we're getting blood coming out of usually signifies some sort of internal bleed somewhere. If they're throwing up coffee ground like substance, bright red, dark tarry stools, or any blood in the stool, and then of course your signs and symptoms of shock. So there's one big bruise, sign of internal bleeding. I don't know why they have blood pressure cuff on that side, but okay. So definitely had a really pretty significant impact there in the shoulder. So maintain your ABCs, internal bleeds. Yes, I understand it's supportive care. And I know as students, you hate that term, but identifying the mechanism of injury. Finding that is hugely helpful to the hospital. You notice bruising and rigidity in the abdomen, and you bring that to someone's attention. That's speeding up patient care. All right, good job. High flow oxygen, control any external bleeds, splinting, keeping your patient warm, and relaying all that information that you found on your assessments is absolutely critical. So all right, it looks like we got a critical thinking one, or the critical thinking case here. So a patient's been involved in an MVC, a motor vehicle, very serious damage to the vehicle. Your steering column and steering wheel are badly deformed. Your patient's talking, that's good, and he's complaining of a sore chest, and you don't see any external bleeding. Here's your vital signs. Okay, your heart rate's 116, respiration's 20, and your blood pressure is 106/70. So I want you to think about how you would proceed to assess and care for this patient. What would you do during your primary assessment? And what would you do during your secondary assessment? And take time and write that out. I think that'd be an excellent exercise for you.